Welcome back to Eye Care Central. Today's lecture is on the anatomy of cornea. As we all know, cornea is the anterior-most structure of the eyeball. It is part of the outer fibrous layer of the eye. The outer fibrous layer of our eye consists of cornea in front and the sclera behind it. Cornea makes about 1/6 of the outer fibrous layer, while sclera makes the rest of it. Cornea is a transparent structure. It is also an avascular structure, which means that it does not have any blood vessels. In fact, it is this avascularity of cornea that contributes to its transparency. It is a convex structure, which means that it converges the rays of light that pass through it. It has an anterior surface and a posterior surface. The radius of curvature of the anterior surface is 7.8 millimeters, while the radius of curvature of its posterior surface is 6.5 millimeters. If we look at it from the front, cornea has a horizontally oval shape. This means that the horizontal diameter of cornea is more than the vertical diameter of cornea. The horizontal diameter of cornea on an average is 11.8 millimeters, while its vertical diameter is 11 millimeters in an adult eye. This means that the horizontal corneal diameter is more than the vertical corneal diameter by about 1 millimeter. When horizontal diameter of cornea is less than 10 millimeters, that condition is known as microcornea. Megalocornea is when the horizontal corneal diameter is greater than 13 millimeters. Please keep in mind that I am talking about the dimensions of horizontal cornea here and not that of the vertical cornea. In this video, I will be asking you 5 questions related to cornea that are commonly asked in ophthalmology viva exams. So the first question is, what is the difference between megalocornea and ophthalmos? If you know the answer, write it down somewhere and wait for the rest of the questions to be asked. You may share all 5 of your answers in the comment section below after the video is over. Moving on, we come to the thickness of cornea. The other word for corneal thickness is pachymetry. Corneal thickness is not uniform throughout the cornea. Cornea is thin in the center and thick at the periphery. The thickness of central cornea in an average adult eye is about 520 microns or 0.52 millimeters, while the thickness of peripheral cornea is 670 microns or 0.67 millimeters. Like the thickness of cornea, the shape of cornea is also not uniform throughout. It has an aspheric prolate shape. To understand the meaning of the word prolate, you need to first understand the terms spheric and aspheric. A spherical surface is one that has a uniform curvature throughout, which means that all the rays of light passing through it converge at a single point. An aspheric surface has different curvatures at different points. For example, in a prolate surface, the center is steep while the periphery is flat, which means that the rays of light passing through the center of a prolate surface are refracted more, while the rays of light passing through the periphery, which is relatively flat, are refracted by a lesser amount. Because of this, the light rays passing through the center converge at a point anterior to the converging point of light rays passing through the periphery. As you can see in the diagram here, there are 2 separate meeting points of light rays. These multiple meeting points give rise to spherical aberrations. In a prolate surface where central rays converge anterior to peripheral rays, negative spherical aberrations are induced. Cornea is prolate in shape, but if we take the average of spherical aberrations induced by cornea, the net effect is slightly positive at plus 0.27 to plus 0.3 microns. An aspheric oblate shape is the opposite of a prolate shape. Here the periphery is steep while the center is flat, and the rays of light coming from periphery converge anterior to the rays of light passing through its center. This brings us to question number 2. What change occurs in the shape of cornea after myopic LASIK? Now we'll discuss cornea's contribution to the refractive system of our eye. Cornea, along with the overlying tear film, represents the anterior refractive surface of the eye. Before reaching the retina, light entering the eye passes through 4 structures: cornea, aqueous humor, lens, and vitreous humor. Here you can see the refractive index of each medium. Aqueous and vitreous humor both have a refractive index of 1.33. The refractive index of cornea is 1.37, while that of the lens is 1.42. The total refractive power of our eye is 60 diopters. Of this, about 44 diopters is contributed by the cornea. The remaining 16 diopters is contributed by our lens. Now we'll talk about the layers of cornea. Cornea has 5 layers in total. From anterior to posterior, they are epithelium, Bowman's membrane, corneal stroma, Descemet's membrane, and endothelium. Recently, a sixth layer known as Doa's layer has also been discovered. We'll be discussing about that too. Some students use a mnemonic ABCDE to memorize the layers of cornea. A stands for anterior epithelium, B stands for Bowman's membrane, C stands for corneal stroma, D for Descemet's membrane, and E for endothelium. We'll start with the epithelium first. Here you can see a magnified view of the epithelium. As you can see, it is a multi-layered structure. Corneal epithelium is a non-keratinized, stratified squamous layer. It is made up of about 4 to 6 layers. The average thickness of corneal epithelium is 40 to 50 microns, and it makes up about 10% of total corneal thickness. Embryologically, it is derived from surface ectoderm between 5th and 6th week of gestation. Corneal epithelium is further subdivided into 3 layers. The topmost layer is of superficial epithelial cells. Below it lie the wing cells or umbrella cells, and the layer at the bottom is that of basal epithelial cells. So the first layer of the epithelium, known as the superficial epithelial layer, consists of 2 to 3 layers of cells. These cells are flat, polygonal in shape. They have extensive apical microvilli and microplicae, which are like little projections on their surface. You can see them in the diagram here. These projections, called microvilli and microplicae, are covered by a glycocalyx layer. They increase the surface area of contact and help in the adherence of tear film. These superficial epithelial cells are tightly packed to each other by intercellular junctions called desmosomes. This prohibits the entry of tears, toxins, and microbes inside the eye. The second layer of epithelium is the wing cell layer or the umbrella cell layer. It is also known as suprabasal layer because it lies above the basal epithelium. It is 2 to 3 cell layer deep, and these cells are less flat than that of superficial epithelium. These cells also possess tight intercellular junctions or desmosomes, just like those present in superficial epithelial layer. Last comes the basal epithelium. It is the deepest layer of corneal epithelium. It is a single layer of columnar cells. Each cell is about 20 microns tall. It is important to note that basal layer is the only layer of epithelium capable of mitosis. These cells rest on a basement membrane or basal lamina. So this is the basal lamina, which is further divided into lamina lucida, which is 25 nanometers thick, and lamina densa, which is 50 nanometers thick. Corneal epithelial adhesion to the underlying layers of cornea is maintained by a basement membrane complex which anchors the epithelium to Bowman's membrane and stroma. This basement membrane complex is a meshwork of anchoring fibrils made up of type 7 collagen, anchoring filaments, and hemidesmosomes. Abnormalities in this bonding system may give rise to recurrent corneal erosions and non-healing epithelial defects. As I mentioned before, of the 3 layers of corneal epithelium, basal cells are the only cells capable of mitosis. New cells arise from basal epithelium. They are pushed anteriorly and they change their shape, transforming into wing cells. These cells continue to move anteriorly and become superficial cells. Finally, they disintegrate and lose their attachments. Basically, the desmosomes connecting them break or dissolve and cells are shed into the tear film. Corneal epithelial cells have an average lifespan of 7 to 10 days. Now, the epithelium of central cornea is not the same as the epithelium present at the periphery. Central epithelium has 5 to 7 layers, while peripheral epithelium is thicker with 7 to 10 layers. Basal cells of central corneal epithelium are columnar, while those of peripheral cornea are cuboidal. Basal cell layer at center is smooth, peripheral basal layer has undulations. Keratin sulfate is present in the basal layer of central cornea, but is absent in peripheral basal layer. There are no melanocytes or Langerhans cells in central cornea, but they are present in peripheral corneal epithelium. The second layer of cornea is called Bowman's membrane or Bowman's layer. It lies anterior to stroma. It is approximately 12 microns in thickness. It is not a true membrane. It is also not a basement membrane. In fact, it is a condensation of the anterior-most portion of stroma. It is acellular and consists of type 1 and type 5 collagen and proteoglycans. These collagen fibers are arranged in a compact manner, which makes the Bowman's layer comparatively resistant to trauma. However, when disrupted, Bowman's does not regenerate, and this leads to corneal scarring. After Bowman's comes the stroma. It is also known as substantia propria. It comprises roughly 80 to 85% of total corneal thickness. It is embryologically derived from neural crest cells. The stroma is made of keratocytes, which are the cells of stroma and extracellular matrix. This extracellular matrix is made of collagen and glycosamine glycans. The main collagen found in corneal stroma is type 1, while type 3, type 5, type 6 and 12 have also been detected. Keratin sulfate is the main glycosamine glycan. Chondroitin sulfate and dermatin sulfate are also present. As I told you before, corneal stroma contains collagen fibers. These collagen fibers are arranged in parallel bundles called fibrils. These fibrils are then stacked in parallelly arranged layers called lamellae. The stroma of the human eye contains 200 to 250 distinct lamellae arranged perpendicularly to each other. Two main theories have been proposed to explain the transparency of cornea. First is the lattice theory by Morris. It says that corneal transparency is mainly dependent on the uniform lattice arrangement of collagen fibrils in stroma. Since both the mean diameter of individual collagen fibril and the space between two collagen fibrils is less than half the wavelength of light, there occurs destructive interference of backscattered light in corneal stroma and cornea appears transparent. The second theory is by Goldman and Bendeck. They said that instead of lattice arrangement, the transparency of cornea depends on interfibrillary distance. The relatively minuscule distance between collagen fibrils relative to the wavelength of light minimizes the possibility of scatter regardless of fibril arrangement. The fourth layer of cornea is called the Descemet's membrane. The average thickness of Descemet's membrane is 7 microns and it is made up of type 4 collagen and laminin. The formation of Descemet starts at 8 weeks of embryogenesis, where it is secreted by endothelial cells which continue to secrete it even after birth. The membrane thickens throughout life. It is 3 microns at birth and can reach up to a thickness of 10 microns in adulthood. Although no elastic fibers are present in Descemets, it exhibits elastic property because of the way its collagen fibers are arranged. So this is what a normal cornea with intact DM looks like. In case of DM detachment, Descemet's rolls up like an elastic membrane. Also, the Descemet's is a pretty tough layer. It is resistant to enzymatic degradation by phagocytes and toxins. This is a healthy cornea and this is what happens during corneal ulceration. These are corneal infiltrates that eat up all the anterior layers of cornea, but sometimes Descemet's remains intact. Due to intraocular pressure exerted by aqueous humor present in the anterior chamber, Descemet's membrane bulges out and forms a descemetocele. Time for question number 3. What is Scholbe's line and what is its significance? The last and the innermost layer of cornea is the corneal endothelium. It is a monolayer, which means that it is a single layer of cells. These cells are cuboidal cells. If we look at the endothelium from the posterior side, the cells are hexagonal in shape and are arranged in a honeycomb-like mosaic pattern. The best way to visualize this hexagonal pattern is by specular microscopy. Corneal endothelial cells are neural crest in origin. At birth, the height of these cells is 10 microns, but over time they flatten and they continue to flatten, and endothelial layer stabilizes at a thickness of 4 microns in adulthood. It is important to talk about corneal hydration while we are talking about the endothelium. Corneal stroma is maintained at a relatively dehydrated state of 78% water content by the action of corneal endothelial cells. We will talk about how the fluid flows into the stroma from aqueous and how it flows out of it. So this is just a representative image of corneal stroma made solely for the purpose of this tutorial. These pinkish images here are collagen fibrils and the green area in between them represents the glycosamine glycans. These glycosamine glycans are hydrophilic in nature, so they have a tendency to draw in water from the aqueous humor. It is to be noted that it is not the corneal cells or the collagen fibers that imbibe water, but it is these hydrophilic glycosamine glycans that swell up. Apart from their hydrophilic nature, these glycosamine glycans also have negatively charged or anionically charged membranes. This negative charge causes two glycosamine glycan molecules to repel each other, creating more space in the corneal stroma for water to seep in. So the negative pressure that develops in the stroma due to these processes is known as the stromal swelling pressure or SP. And the pressure with which the fluid moves into the stroma from the aqueous is called the imbibition pressure or IP. Now if we think about it, the stromal swelling pressure and the imbibition pressure should be equal, because the pressure with which the fluid moves into the stroma, that is the imbibition pressure, should be the same as the pressure that is present inside the stroma, which is the swelling pressure. But in reality, there is a third pressure at play here, which is the good old intraocular pressure. The intraocular pressure presses against the stroma, working against the stromal swelling pressure, trying to wring fluid out of it. Thus, the net imbibition pressure is the difference between the intraocular pressure and the stromal swelling pressure. So this was how the fluid influx takes place. What about the efflux of fluid so as to maintain the corneal stroma at a steady state of hydration? The first mechanism behind it is the corneal endothelial pump mechanism. We'll talk about two endothelial pumps here. The first is the sodium-potassium ATPase pump, which works by pumping sodium ions into the aqueous, thereby creating an osmotic gradient between the aqueous and stroma, leading to the movement of fluid from a hypoosmolar stroma to a hyperosmolar aqueous. So in this diagram here, these are the endothelial cells of the cornea. On the left is the stromal side and on the right is the aqueous side. The side facing the stroma is called the basal surface of the endothelial cells. The side facing the aqueous is called the apical surface, and the other two sides are the lateral surfaces. These are the tight junctions or gap junctions connecting the endothelial cells with each other. These cells are called leaky junctions because they allow the influx of fluid from the aqueous to the stroma along the imbibition pressure that we talked about earlier. So coming back to the endothelial cells, the sodium-potassium ATPase pump is located on the basolateral surface of an endothelial cell. It pumps out sodium ions into the aqueous humor, which in turn causes the passive movement of fluid from the stroma to the aqueous along an osmotic gradient. The second pump that is present at the endothelial level responsible for maintaining corneal hydration is the carbonic anhydrase pump. The carbonic anhydrase pump is located intracellularly, unlike the sodium-potassium pump that is located on the surface of the cell. It causes active transport of bicarbonate ions into the aqueous humor. This collection of bicarbonate ions generates a negative electrical potential on the aqueous side of the endothelium. This causes movement of positively charged ions, leading to the efflux of fluid from the stroma by a pull effect known as electro-osmotic gradient. Besides the endothelial cells, the corneal epithelial cells also have a role to play in corneal hydration mechanics. As mentioned before, epithelial cells are connected to each other by strong and tight intercellular junctions called zonular ocular dens or desmosomes. These junctions seal the space between epithelial cells, rendering them relatively impermeable to tears that are present on the external surface of the eye. The swelling of stroma occurs from posterior stroma to anterior stroma. The reason being that first, different types of proteoglycans are present. Posterior stroma has keratin sulfate, which is more hydrophilic and tends to imbibe water, while anterior stroma has more dermatan sulfate that is relatively less hydrophilic than keratin sulfate. The second reason for this difference in hydration pattern between anterior and posterior stroma is the way the collagen lamellae are organized. In anterior stroma, the collagen lamellae are more tightly packed, while in posterior stroma, they are packed loosely, allowing more hydration. Now coming to endothelial cell count, in newborns it is 4000 to 6000 per square millimeter. In adults, the endothelial cell count is about 2500 cells per square millimeter, while in old age it reduces to 2000 cells per square millimeter. The rate of attrition of endothelial cells, which means the rate at which they decrease in number, is 0.6% per year in normal corneas, which means that a normal cornea loses 0.6% of its endothelial cells every year. When the endothelial cell count goes below 800 cells per square millimeter, the risk of developing spontaneous corneal edema increases manyfold. These endothelial cells don't have the ability to divide or replicate. Cells are lost with time due to many factors like age, trauma, surgery, inflammation, endothelial dystrophies, etc. In such scenarios, the remaining endothelial cells stretch in order to take over the space created by lost degenerated endothelial cells. So here this is a perfectly healthy corneal endothelium with uniformly sized hexagonal cells. When some of these cells are lost, other cells grow in size to fill in the space. This growth in size is known as polymegathism. They also lose their hexagonal shape. This change in shape is known as pleomorphism. So here you can see many pleomorphic cells and polymegathism as well. Again, I must add that this is a representative diagram. You can observe these changes best on specular microscopy. Question number 4. At what layer of cornea is KF ring seen? So recently a new layer of cornea was recognized known as the Duas layer. This layer was first reported by Dua et al. At the University of Nottingham and was published in Ophthalmology journal in the year 2013. This layer is a well-defined acellular strong layer located just in front of the descemex, or we can say in the pre-descemex cornea. It consists of only 5 to 8 lamellae of collagen fibers. The thickness is just 6 to 15 microns. It is devoid of any keratocytes, which makes it an acellular layer. Dua et al. Demonstrated its presence by the big bubble technique, which is used in lamellar keratoplasties. So big bubble technique is a technique that is used for lamellar dissection of cornea, which means the separation of corneal stroma from the underlying descemetes and endothelium for partial thickness corneal grafts. So what they did was they injected air into the corneal stroma using a 26 gauge needle and formed a big bubble, and then they stripped off the descemetes. They noticed that even after removal of the descemetes, the air bubble maintained its shape. It did not pop. This confirmed the presence of another thin but strong layer just anterior to descemetes that was impervious to air. This was named as the Dua's layer. The understanding of this layer could have a role in posterior corneal surgeries and in the understanding of corneal biomechanics and posterior corneal pathologies like hydrops, descemetocele, pre-descemetes corneal dystrophies, etc. Before we move on to the blood supply and nerve supply of cornea, here is the fifth question of the video. What is the difference between type 1 and type 2 big bubble? Our next topic of discussion is blood supply of cornea. Cornea is an avascular structure, which means that it does not have any blood vessels. It gets its nourishment from the aqueous humor and from the vascular arcade that is present at the limbus. This vascular arcade originates from the anterior ciliary artery. These limbal vessels help in corneal metabolism and wound repair. Normally, the limbal vessels extend up to 1 mm into clear cornea. Corneal neovascularization is a condition in which abnormal blood vessels develop in the cornea. So here you can see a healthy avascular cornea, and now corneal infiltrates have developed on it. Blood vessels reach the infiltrate to help in healing of the ulcer, resulting in a corneal scar. After healing of infection, the new vessels that are formed turn into what we call ghost vessels. Ghost vessels are empty transparent vessels that persist in cornea after regression of the inflammatory process that stimulated their development. Our final topic is the nerve supply of cornea. Cornea is one of the most heavily innervated and sensitive tissues of the body, and the density of nerve endings in cornea is about 300 times than that of the skin. So the story of its nerve supply begins at the trigeminal nerve, which is the fifth cranial nerve. 3 branches arise from the trigeminal nerve: the ophthalmic nerve, the mandibular nerve, and the maxillary nerve. The ophthalmic nerve is the first division of trigeminal nerve, and it further gives off 3 branches: the frontal nerve, the lacrimal nerve, and the nasociliary nerve. The nerve supply of cornea is by the nasociliary nerve. It gives off 2 long posterior ciliary nerves. One is the nasal long posterior ciliary nerve, and the other is the temporal long posterior ciliary nerve. Also, there is a ciliary ganglion that gives off 5 to 10 short ciliary nerves. These long posterior ciliary nerves and the short ciliary nerves pierce the posterior part of sclera to enter the globe. They run in suprachoroidal space where they give off several branches and anastomose with each other and with the conjunctival nerves to form the pericorneal plexus of nerves. They perforate the sclera just behind the limbus to enter the corneal stroma. 3 plexuses of nerves are present in the stroma. First is the stromal plexus, which lies in mid-stroma. Then is the subepithelial plexus that lies between the Bowman's and the anterior stroma. Last is the intraepithelial plexus that lies between tightly packed epithelial cells, and this is where the nerve endings terminate as intraepithelial free nerve endings. The reason why epithelial defect is such a painful condition is because these free nerve endings get exposed and irritated. A quick question arises: are corneal nerves visible normally? The answer is yes, they are. They can be visualized as thin fibers in peripheral cornea because peripheral corneal nerves have a thicker diameter than central corneal nerves. That is all for today's video. If you found the video useful, please like it and share it with your friends and colleagues. If you want more such videos, then do let me know in the comment section below. Also, don't forget to subscribe to this channel for more such videos. Have a good day. Thank you.